So today I'm going to talk to you guys about congenital oral atresia. I'm going to specifically focus on malformations of the ear canal and malformations of the middle ear. I'm not going to be talking about microsia, which is malformations of the pinna, which many children or adults usually have both. And I'm not going to be talking about malformations of the inner ear. So we're just going to focus today on ear canal and middle ear. The knowledge of congenital oral atresia has been known for a very long time. It was first described in 2000 BCE. It was in the teratological tablets of Mesopotamia. By 600 BCE, it was once again described in the tablets of the Assyrio-Babylonians in the library of the Assyrian king. This is the Assyrian king here, Assurbanipal, and I apologize if I'm mispronouncing the names.
Did they reference the earlier notation?
I'm sorry? See, no reference, yeah. They were really bad at plagiarizing at that time. Around 500 BCE, there was an Ayurvedic surgeon named Sushruta. And I'd like to digress a little bit on Sushruta because this, my father's a surgeon, and so this print has been in my father's office for as long as I can remember. So I've been very intrigued with him because I've been told, oh, this is this famous surgeon from a long time ago who did all these surgeries. And it's kind of funny now that I'm actually in head and neck surgery because he's most famous for the paramedian forehead flap. He's also famous for otoplasty. He described different flaps to correct the malformations or traumatic or congenital malformations of the earlobe. So I was like, okay, he must have described, if the Babylonians were talking about it, if the Mesopotamians were talking about it, he must have mentioned congenital oral atresia. So I actually have a English translation of his book. It's a very thick book, and I didn't read it thoroughly, but I did skim it, and I could not find any mention of atresia. So I was really upset about that. But I did find that he described 28 afflictions to the ear. Most of them are like otorrhea, tinnitus, hearing loss. He talked about 31 nasal diseases, including CSF rhinorrhea, which I thought was pretty impressive. He also talked about 65 diseases of the oral cavity, including oral cavity cancer and ranulus, but no atresia. So time passes, and the first mention of actual atresia surgery was in 1845 by a British surgeon named Thompson. And he actually didn't do this surgery. He described other people doing this surgery, and he described 3 surgeries. And in that paper, all they did was make an incision, look at solid bone, and then close. And he described atresia surgery being an insuperable obstacle. You can't do it. The first surgeon to have actually tried to drill the bone was Dr. Kisselbach, famous for the Kisselbach plexus. He's a German surgeon, and he performed atresia surgery on a small child and unfortunately got a facial nerve paralysis. So really, advances in atresia surgery management and treatment really happened in the 20th century, and mainly in the second half of the 20th century. And I hope today to touch on some of these events, as well as others that I did not mention on this timeline. So my objective today is to describe to you diagnosis and evaluation of atresia. I would like to go over the surgical technique of atresia. Then we're going to go over the outcomes, including complications as well as hearing outcomes. And then I'll touch base on alternative therapies. So let's start with the case presentation. This is AV. She's a 19-year-old female who presented to Dr. Ogilvie's clinic with a malformed pinna on the left-hand side and a lack of the ear canal. This is really AV, by the way. On examination, she had no medical problems. She had never had surgery for this, no hearing treatments for this. On examination, she had a grade 1 microsia, an absent external auditory canal, and she had normal facial function. This is her audiogram. As you can see on the right-hand side, she had normal hearing. But on the left-hand side, she had almost a maximal conducted hearing loss with a speech recognition threshold of 55 decibels, consistent with her atresia. Because she had a normal hearing on the right, she had never received any type of hearing rehabilitation for her surgery. I'm sorry, for her atresia, for hearing loss on her left-hand side. So, congenital oral atresia occurs in about 1 in 10,000 to 1 in 20,000 births. Unilateral, like AV, is more common than bilateral. The right ear has been shown to be more common than the left. Males have it more commonly than females. 10% are associated with a syndrome such as Treacher-Collins or hemifacial microsomia, which falls into a bigger spectrum of oculo-auricular vertebral syndrome. And there's been some recent genetic studies that look at deletion of the chromosome in long arm of chromosome 18, to be associated with atresia. So how does atresia occur? So we need to go over some embryology. So the formation of the ear canal and the middle ear has to do with the joining of the ectoderm of the first branchial groove and the endoderm of the first branchial pouch. This starts at about 5 weeks gestation. The development of the ear canal and the middle ear occurs from 5 weeks to about 30 weeks gestation. Around the same time at 5 weeks, mesenchyme from the first and second branchial arch start to form the beginnings of ossicles. By 10 weeks, the first branchial pouch starts to form a tubotympanic recess. This is a slit-like projection from the distal end of the pouch. And there's further formation of the external auditory canal from the groove. You can also start to see further formation of the ossicles. They start to look more like the structures we see during surgery. By 27 weeks, the tubotympanic recess enlarges and encompasses the ossicles and becomes what we know as the middle ear. And by this point also you have the eustachian tube as well as the external auditory canal. And this is all done by 27 weeks. Now, let's take a moment here and discuss microsia. I said I wasn't going to talk about it, but I did tell you that it's closely associated with it. Microsia occurs from the first and second branchial arches, so it's the same embryologic derivative, but it happens simultaneously, and they're somewhat independent. Usually from this is the first and second branchial mesenchyme, and because they're from the same embryologic derivative, they are associated about 90% of the time. But 10% of the time, atresia can happen alone. Now, the inner ear is formed from the otic placode, which is ectoderm, and it's from a totally separate embryologic source. And it invaginates and forms the oticis and eventually the labyrinth. But because it comes from a different source, it is only associated with atresia about 10% of the time. So the first person to classify atresia was Dr. Altman in 1955. And he looked at about 59 temporal bones in patients who were now they're not alive, but they had congenital oral atresia. And he divided them into 1, 2, and 3, or mild, moderate, and severe. So the mild patients had an external auditory canal and a normal middle ear, but the external auditory canal was hypoplastic. The moderate patients had basically an absent ear canal with a diminished middle ear and malformed ossicles. There was usually a beginning of an atretic plate. And the group 3 patients, or the severe patients, had an absent external auditory canal, and the middle ear was even more hypoplastic or completely missing. Now, Dr. Shupnik in 1989 reclassified atresia in this paper, and this is what is typically used in most in subsequent papers. He divides atresia into A, B, C, and D. So class A is basically stenosis of the cartilaginous ear canal. There's a normal bony ear canal, a normal tympanic membrane, and a normal middle ear. And these patients generally are at risk for canaloplasticoma. Type B is usually a narrow, tortuous ear canal, so it's stenotic both at the cartilaginous portion as well as the bony portion, but the middle ear is normal. There's also a beginning of an atretic plate. Type C and D are more the classic atresia that we talk about. It's a complete stenosis of the ear canal, a complete atretic plate, and this is when the first branchial groove and first branchial pouch do not meet. And also it's associated with the malformation of the tympanic bone as a temporal bone. What differentiates type C and type D is that type C has a hypoplastic middle ear and malformed ossicles, but type D is even more hypoplastic and more malformed. So when a child is born with atresia, the patient must undergo both evaluation and counseling. So the most important thing is to do a hearing evaluation, both audiometrically as well as radiographically. Usually this is done by an ABR, and they usually get a CT temporal bone. Genetics evaluation is also important, as many of these children are born with other congenital anomalies. They also need to undergo counseling, the parents especially, for if they decide to have other children. Speech and language counseling is really important because even in children with unilateral hearing loss, they are, even if it's conductive, they are still 10 times more likely to fail a grade. They are 10 times more likely to have a behavioral problem and have need for educational assistance. Psychosocial counseling is also really important because it's very devastating to the parents and even the child as they get older when they have an abnormal ear. And then generally, the child is followed regularly to make sure that there's no evidence of cholesteatoma, as these children are at risk. So, who gets an atreidoplasty? Who gets reconstruction of their ear canal? So back in the 16s, so you have to have congenital aural atresia, and you need to have a normal inner ear. You need to have both a normal audio, you have to have an audiogram that shows that the inner ear is working, as well as normal anatomy seen on a CT temporal bone. Now, back in the 60s and 70s, atresia surgery was only done on patients who had bilateral atresia. And that's because the risk of surgery was really high. There were a lot of complications, but these patients had significant hearing loss, and the benefits of trying to help their hearing outweighed the risks of complications. By the late 70s and early 80s, with the increased use of temporal bone CT scans, surgeons started talking about doing surgery on unilateral atresia. And it was mainly argued that there was a benefit for binaural hearing, mainly hearing in quiet environment, hearing in noise, distance hearing, and sound localization. So, by the late 70s, people were describing it. Surgical technique had improved, and there was noted benefit in doing surgery on unilateral ears. So today, when a patient has congenital aural atresia and has normal sensorineural hearing, if they have a unilateral atresia, usually nothing's really done because they have a contralateral good ear. By the time they reach age 5, if they have like a grade 3 or a grade 2 microsia, they are evaluated for reconstruction. And once they reach an age where they're old enough to understand the risks of surgery, as well as can participate in the postoperative care, Atreidoplasty is considered versus a bone-anchored hearing aid, which I will talk about later, versus observation. In those who have bilateral congenital aural atresia, because they have a significant conductive hearing loss, they are usually offered a soft band bone conduction hearing aid early on to maximize their auditory environment. And then, because they have a bilateral atresia, they're sometimes evaluated early for atreidoplasty versus getting a more permanent bone conduction hearing aid, or they continue to wear the soft band bone conduction hearing aid, and then once they reach age 5, they're evaluated for the Microsia surgery. And after age 5, then you start considering whether you do atreidoplasty on the opposite ear, or if they haven't had it already, they will reconsider at this point, or they'll get Bajas on one ear or both ears. Now, I would like to stop here and talk about Microsia surgery one more time. I know I did not want to talk about it, but classically, Microsia repair is done before atreidoplasty. And the argument that is that you do not want to disrupt the surgical planes that is necessary for a good uptake of the fibrocartilage rib graft that you harvest and place there. So the thought is, if you do an atreidoplasty first, your rib graft is not going to take. There are some surgeons out there who write that we don't have our priorities straight and that we are placing cosmetics over function, and argue that we should be thinking about atreidoplasty earlier. You might extrapolate that we should be thinking about just hearing rehabilitation earlier for bilateral hearing. So there are a couple of times in this algorithm where atreidoplasty is considered, but not everyone is a candidate for reconstruction of their congenital aural atresia. And with the advent of increased use of CT temporal bones, surgeons started to become more, they started to understand which patients were better candidates for surgical treatment and which ones would have a better surgical outcome. So the first person to write about a radiologic grading system was Dr. De La Cruz in 1985. And he divided atresia based on CT temporal bones into major and minor malformations. Now, if a patient had minor malformations, they had a better likelihood of having a good surgical outcome with good hearing results. So if they had a normal mastoid pneumatization, normal oval window, the facial nerve was in a reasonable place, though, and he goes into it, and we'll go into what that means, and a normal inner ear, these patients would have a better likelihood of having a good surgical outcome. However, those patients who had major malformations probably shouldn't touch. Now, Dr. Yarsdorfer in 1992 published a paper which most people use today and described a 10-point radiologic grading system. In this, if you have greater than 8, or usually a 7 or 8, you have a better likelihood of having a good surgical outcome. And I'd like to point out, as most of us know, the stapes, the presence of the stapes had a greater weight as we gave it 2 points. So let's look at ABCT smear. For those of you who just walked in, AB is a 19-year-old with a grade 1 microsia and an external auditory canal coming to see us for evaluation. So this is a left-sided ear. This is an axial cut CT temporal bone windows. We're starting from the bottom to the top. And as I scroll through this, you first notice she's got a grade 1 microsia. We already knew that. She's got a small mastoid, but the mastoid is relatively well pneumatized. You're starting to see the facial nerve right here. This facial nerve is a little bit more anterior laterally placed, but it's still, in the mastoid cavity, far away from the middle ear. As you go further up, you start to see its second genu. You can now see the middle ear is pneumatized. And then you're starting to see the stapes here. Here is the second genu. And as it comes up into become the tympanic segment, it's superior to it, so it's well away from the oval window. Now you're also starting to see ossicles. And so if you actually calculate her Yarsdorfer criteria, she's about a 9 or a 10 out of 10. She also has a normal inner ear. This is a slide to show, just kind of focus on the stapes. Here's the axial cut of her stapes. You can see our anterior and posterior crus. And you can also see the incutostapedial joint here. So AB is a great candidate for Atreidoplasty. She's a Yarsdorfer 9 out of 10, and she has a grade 1 microsia. She's a great candidate. So what are the goals of surgery? 3 main goals are: you want to have a clean, dry, epithelialized canal. You want to have a patent meatus, and the reason for that is that post-operatively in the clinic, you want to have a nice big meatus that you can look into that ear and debride it regularly. But the most important is that you want to improve the hearing. You want to close the airborne gap. So I'm going to describe to you the anterior approach to Atreidoplasty. Now, there's also the mastoid approach to Atreidoplasty, and I'm not going to describe that to you today because this is actually what's typically described, classically used by most surgeons who do Atreidoplasty. It was described by Dr. Yarsdorfer in his 1978 paper. A mastoid approach is basically a fancy canal wall down. The anterior approach consists of 5 major steps: incising and drilling the ear canal, harvesting a split-thickness skin graft, placing a temporalis fascia as the new tympanic membrane, placement of a skin graft along the new external auditory canal, and then a metaplasty. So let's start. So first thing you want to do is make a postauricular incision. You go down to the periosteum. You want to harvest temporalis fascia at this time. Very typical for your normal tympanomastoidectomy. Very typical to that type of surgery. Once you've retracted the soft tissues, some people have described a posteriorly based periosteal flap, though I know some surgeons do not do this. Then you want to start drilling your ear canal. Now, you want to identify the temporal line, and you want to identify the posterior rim of the glenoid fossa. Now, you don't have an ear canal, so basically your temporal bone is right next to your jaw joint. And you want to stay high and superior and start drilling right about here. Now, the reason you want to do this is that if you stay high and superior and follow the tegmen, you enter the middle ear superiorly into the epitympanum. And this is the safest way to approach the middle ear without hurting the facial nerve. You, at this point, would identify the atretic plate, which you remove, and then eventually widen the ear canal to about 1.5 times the size of a normal ear canal. Now, when you remove this atretic plate, there's a couple of things you have to think about. The ossicles, the malform malleus and incus, you typically attach to the atretic plate. So as you drill down, you usually switch to a diamond burr, and then eventually you start to slowly chip away at this atretic plate with care not to jostle the ossicles. Now, some surgeons describe using a laser here to minimize any type of ossicular movement. The reason being is that you don't want to jostle these ossicles because they are connected to your stapes and the inner ear, and there's some thought that you can cause some acoustic trauma. So once the atreidic plate is removed, you want to drill an ear canal with ossicular complex, the malformed one, being in the center. You palpate these ossicles and you look at it whether there's actually an incudostapedial joint. If this joint does not exist, you can take out the ossicles and place a port or a torp. The temporalis fascia is then placed over the ossicular complex or the port or torp. Now, this temporalis fascia is not really anchored against anything. There's nothing anterior holding this fascia down. So it's really important that the anesthesiologist is not giving any type of nitrous gas that will separate it from the ossicles. This is a side view of it. And then what you want to do is usually you'll harvest a skin graft from the forearm, hip, or the thigh. It's about 6 by 4 centimeters in size. The thickness has been described as 5 to 6 per 1,000 inch. I know some people do it thinner than that. You want to make notches on one end, and you place the notch end over the temporalis fascia, and then lay the rest of the skin graft against the ear canal bone that you just created. A silastic button is generally placed over the temporalis fascia and the skin graft, and then Maricel wicks or whatever packing of your choice is placed over that to stent open this newly formed canal and keep the skin graft against the bony canal. Then a Metaplasty is performed. Some people describe an anteriorly based skin flap that's attached to the tragal skin. Some people don't even do this; they just create a big hole here. And then you can sew the meatal skin, the anterior portion, to the periosteum, or you don't have to do that. And then you lay the skin over the fibrocartilage external auditory canal, and then you sew the meatal skin to the skin graft. You place more packing, and you're done. Now, these patients, some of them, if they're young, will stay in the hospital one night. Most adults will go home. They generally are seen 1 week postoperatively to remove the pack, and then 1 month later for debridement and their first audiogram. So, AV had surgery this past Monday, and I was fortunate to be present. I was the paparazzi and did not get to operate. These are the surgical pictures from Dr. Oglai, Dr. Gurgal, and Dr. Chan. I really wanted to do video footage for you guys, but I unfortunately am very computer illiterate, and I spent the last 3 days trying to convert the video file to something that the Mac. I thought the Mac was some type of amazing contraption, but could not read the file. So I'm sorry. You can pretend like there's hands moving, but there really aren't in these photos. So this is AB. She's marked, ready to go. She's prepped and draped, and we make a postauricular incision right about here and elevate the soft tissue. Now for AV, we did not do a periosteal flap. We went straight down to bone. Here's the temporal line. This is the left ear, just to remind you guys. This is actually her temporal mandibular joint. It kind of looks like an ear canal, but it's the temporal mandibular joint. We started drilling right about here. Remember I said you want to say high superior. You want to hug the tegmen. The ear canal is starting to be drilled. We did kind of see a little bit of dura there, but I won't say who got into that. Sorry. It was bipolar, it's okay. She's doing fine. We get down to the atreidic plate. Here's the atreidic plate being drilled down. Here are ossicles. This is also described as the buttock sign. It's actually described in a paper. It's not just a sign, because apparently it looks like a little baby's bottom. Anybody's bottom, I guess. Here's the handle of the malleus. It's just typically shortened, but for her, she actually had a pretty decent size. As we tapped on the ossicles, you could see the ossicles actually moved. We had a great video of this. I could not show it to you guys, but it was actually attached right here. And I understand this is classically where the ossicles are attached to the atreidic plate. You can also start to see the incus and the stapes right here. This is the ear canal drilled out. Ossicles are nicely in the center. We have a nice ear canal. We then took our temporalis fascia, which we had previously harvested. We had laid it out to dry on a number 8 speculum, kind of to replicate the size of the tympanic membrane we were trying to form. The temporalis fascia is placed. Then we harvested skin graft from her thigh and placed pieces along the new external auditory canal. Then the skin graft was then laid against a pack, which we placed on top. We did not use a silastic button for this patient. Like I said, a lot of these are, surgeon's preference. And so the skin graft was laid against the pack. Then the Attenuation was created, a hole where her external auditory canal would be in relation to the pinna. You can see the pack here and the skin graft against that pack. It was then relayed out and then sewn to the meatal skin. And this is her right soon after right at the end of surgery. And it's been 1 week, so I don't have anything else in terms of her postoperative assessment, but I'll be following her to see how she does. So some surgeons, some surgeons talk about using CT navigation. We did not use CT navigation, but there are some people who think that with the advent of CT navigation, it can help with external auditory canal planning, the trajectory planning. It would help with anatomic identification, for example, helping to identify the facial nerve, helping to identify the traumatic plate, the horizontal semicircular canal. Some of the bigger arguments that this paper, this is from Switzerland, described was safety and confidence for the surgeon, as well as you can teach your fellows and residents without freaking out in the OR. But the disadvantages that he described was cost. I mean, using a CT navigation system is very expensive. He did not show any time saved. So he actually looked at his patients before and after the use of CT navigation, and he did not find that he saved any time, because the time he saved using the machine, he used it to set up the machine. He did not find any improvement in the hearing outcome, and he says he expected that because it helps with the actual anatomic identification, but does not help with the reconstruction. And actually, if you look carefully at his papers, he talks about how it helps you identify all these structures and helps you prevent complications, but his complication rate before and after the use of the CT navigation was no different. There was no actual benefit in terms of complication rates. So, by the way, this is the DRF. This is what some surgeons use when they use the Medtronic fusion machine for temporal bone navigation, because you can drill this into the temporal bone and it allows accurate identification, accurate navigation. So what are the complications? There are a number of complications. The most common one is that you can have meatal or canal stenosis. This occurs about 3 to 20% of the time. Now, stenosis on the ear canal is expected, but complete stenosis or stenosis to the point where the ear is not functional happens about 3 to 20% of the time. You can initially try to treat it with steroid injections or by having them using mineral oil-coated earplugs at night, but most of these patients require revision Metaplasty. Another complication is otorrhea, having a chronic draining ear. And this is usually due to the fact that mastoid air cells are open during the Atreidoplasty, and rather than the skin graft taking in the ear canal, you get mucosalization of the ear canal. These patients require revision skin graft. Lateralization of the tympanic membrane occurs pretty frequently. This is because there's nothing to anchor that tympanic membrane down, or the neotympanic membrane down. Refixation of the ossicles is also common. All of these complications can be treated by a revision Atreidoplasty or revision surgery. And if you look at the literature, about 1/3 of patients look like they need a revision surgery after their initial surgery, which is, I personally think, is really high. It's 33% of your patients are going to fail their surgery that you're telling them is going to help improve their hearing. Now, what about irreversible complications? Well, the most scary one is facial nerve injury. And when I look in the literature, it's described as low as 0.1% to about 11%. Now, I think 11% is a little bit high. I think most people would say it's in the less than 1% range, but some people are saying they get 11% injury. Now, why is the facial nerve such a risk? And this has to do with the development of the facial nerve in relation to the ear canal and the middle ear. Now, this is a surgeon's view of a right ear, and you can see the tympanic segment coming down, the second genu. And in normal ears, you get about a 95 to 120 degree turn. in the mastoid segment when you switch into the mastoid segment of the facial nerve. Now, atretic patients can have a curve as high as low as 60 degrees, and which puts your facial nerve literally right lateral to your middle ear. This occurs because the facial nerve's final position is dependent on the actual development of the middle ear and the external auditory canal. So around 10 weeks, 10 weeks gestation, everyone's facial nerve looks like this. But as the middle ear develops and the tympanic ring develops and the ear canal develops, it pushes this facial nerve posteriorly and inferiorly. So in patients with a malformed middle ear and ear canal, this is what you have. You have a facial nerve that's like a 10-week gestation. It's at the spot where a 10-week gestation fetus would have their facial nerve. And this is what puts the facial nerve at risk when you are operating. This picture also illustrates why you want to stay kind of high and superior when you enter the middle ear, because anywhere else the facial nerve is free game. So this is AV CT scan, just to review. And here's her right ear, which is her normal ear, and you can see her facial nerve right here, her descending portion of her facial nerve right here. Her facial nerve on the left-hand side is already exited. It's so anterolateral, it's exited already. Basically, not in the stylomandibular foramen, we're exiting at the near the glenoid fossa. So there was a paper from China. It was published by a bunch of otolaryngologists as well as by neuroradiologists. They looked at the CT temporal bones of patients with atresia and looked at their facial nerves on the scan and then compared it to the surgery that they did. And they came to the conclusion that the mastoid segment was predictable. What you saw on the CT temporal bone, you could see it intraoperatively. And they found that the mastoid segment was over the round window, over the oval window, 50% of the time, over the oval window 10% of the time, and over the cochlea 7% of the time. The tympanic segment, however, was not as predictable. You can predict whether it's dehiscent or not, and they found that it was dehiscent 50% of the time, but it could be found over all these locations here, and many of the times very difficult to identify, and both on the CT scan and correlate on intraoperatively. So Dr. Yellen from Pittsburgh looked at CT temporal bones himself and with a neuroradiologist, and he felt that the facial nerve required 2 points, just like the stapes. And he published this paper recently and said we need to give a point for the facial nerve's position in the middle ear, and I believe that what he meant is like where it was in the mastoid segment, lateral to the middle ear, and then the facial nerve's position in relation to the oval window, and that was mainly the tympanic segment. So recently, there's been a lot of surgeons and neuroradiologists trying to really characterize the facial nerve, because this is what is the most scary complication. You do not want to trade a facial nerve paralysis for a working ear, especially if you have a good ear on the contralateral side. Dr. Yellen did not validate this intraoperatively, by the way. So the other major irreversible complication is sensorineural hearing loss. And the reason patients get sensorineural hearing loss about 3 to 5% of the time is because of acoustic trauma. It's believed that they get a high-frequency hearing loss from drilling on the atretic plate and manipulation of the ossicular mass. And it's usually about a little notch in about 4,000 hertz. And in the mid to late 90s, the laser became very popular in trying to chip away at the atretic plate. However, Dr. De La Cruz and Dr. Truffaut looked at their patients before and after the use of laser, and they did not find any difference in their outcomes in terms of sensorineural hearing loss. So I think it's not really clear whether the laser really helps or not, but it is clear that there's some element of acoustic trauma when during atreidoplasty. So I just described to you a very complicated surgery. It's been described by some otologists being one of the most difficult, tedious surgeries to do. Described to you complications, some reversible, but some of them irreversible. But they're relatively high percentages. But I guess if you look at the goals of surgery, if we can achieve these, maybe it's worth those risks. Specifically, if you improve hearing, I think if you have a good hearing outcome from the surgery, maybe it's worth putting the patient at risk by doing an atreidoplasty. So I looked into the literature trying to figure out what is the hearing outcome, typical hearing outcome in a patient who gets Atresia surgery. And I think the first question I had to figure out is, what defines success? Is it an improvement in the air bone gap? Is it an improvement in the SRT or the PTA? And if so, by how much? Is it a reduction in the interaural difference? Because if a patient has a 20 dB or higher difference between both ears, the patient's going to always think their better ear is hearing better, and they're never going to feel like the ear you operated on had improved. Is hearing gain the way to measure outcome, and that's the difference in the pre- and post-operative PTA? Or is the need for an aid, or the lack of a need for an aid, is that what would be a successful outcome? Meaning that if you could get a ear that you do not need to have any type of extra contraption, is that though how you define it? And unfortunately, I don't think anybody in the literature has come up with a good way to really look at this. And the results are all over the place. What I did find is that most surgeons will define their hearing outcomes based on an SRT less than 30 dB, an air bone gap if it closes below 30 dB, or they look at their average hearing gain. This is kind of the ones that are classically used. Now, if you look at SRT less than 30 dB, you can first of all notice it's in the older literature, but the numbers look like, if you look at them, they're probably about 60%. So that means that 60% of patients will get an SRT less than 30. Now 30 is pretty conservative, right? Normal hearing is between 0 and 20. So they're saying 30 dB is a good hearing outcome. If you look at air bone gap, which are some of the more later papers, people are quoting maybe about 70%, reducing the air bone gap to less than 30. Not to 0, but to 30. And then if you look at the average hearing gain, people are describing about a hearing gain of about 20 dB. This being very conservative. So a couple of things I also want to point out is that the hearing results get worse with time. For example, this Lambert paper from '98, he had 70% of his patients had an SRT less than 30, less than 1 year, but they dropped to 50% greater than 1 year. And that's consistent, for example, if you look at air bone gap, Shelton's paper here went from 82% to 50%. The same thing with hearing gain here in Chang's paper. So hearing drops with time. The other thing I want to mention is the only paper that actually looked at interaural difference was Dr. Cueva's paper from 2006. And he said he could get an interaural difference of 20 dB in about only 30% of his patients. And he can only get interaural difference of 30 dB in 60% of his patients. So I think for the most part, we can kind of sum it up to being this. Atreidoplasty, you can get an SRT less than 30 about 60% of the time, an ABG less than 30, about 70% of the time, and a hearing gain about 20 decibels. So this begs the question, is there a better way to improve hearing? A better way to improve hearing without putting the patient at risk for all these complications from an Atresia surgery? Perhaps, if you vibrate the bone and you avoid the air conduction apparatus, you just vibrate the inner ear, perhaps you can get just as good hearing this way and avoid an Atresia surgery. And this is the concept of bone conduction hearing. Now, bone conduction hearing also dates back to many, many years ago. But the majority of it occurred during the 20th century. The first mention of bone conduction hearing was during the Renaissance. There was an Italian scientist named Girolamo Cardano who demonstrated that sound could be transmitted by a rod held within the teeth. And this was mainly used to hear musical instruments. I'm not exactly sure how, but that's what this paper on the history of Baja said. By the 1950s, with the advent of microphones, people started using a bone conduction vibrator placed on a mastoid, and this was held by a headband or by glasses. By 1977, Dr. Hjelström from Sweden placed the first osteo-integrated implant. This was otherwise known as the Baja. And of course, in the 2000s, there's the development of the SoundSight. So this is your bone conduction hearing aid. You have a microphone that's kept over 1 ear, usually the atreidic ear. It's connected by a steel headband to the oscillator that's on the contralateral ear. So this, in fact, is vibrating the contralateral ear. So it's in fact kind of acting like a cross hearing aid. The other downsides to this type of hearing aid is, one, you cannot wear this you cannot you cannot have a bilateral hearing aid because you're using both sides for just one device. It's also really uncomfortable. Many patients complain that this is very painful to wear and they just don't like it. So when we compare Atreidoplasty, most people compare it to the bone-anchored hearing aid. So this is the hearing aid that Dr. Yellstrom first placed in 1978. And it consists of a titanium fixture placed about 5 to 6 centimeters behind the ear that's osteo-integrated into the bone. And what is great about the Baha is that the microphone and the oscillator are kept in one device, and so that everything is on one side. So the benefit of the bone-anchored hearing aid is that it's unilateral, so therefore you can place a hearing aid on both ears. The other benefit is that they developed one called a soft band bone conduction hearing aid, which is basically the same device that's attached to an elastic band, such that younger children who don't have the skull thickness ready for an implantable device, they can have a similar device and optimize their hearing early. So the Baha is FDA approved for patients who are greater than age 5. But the literature shows that that children who are as young as age 1 can tolerate the Baha. It requires 3 to 4 millimeters of skull thickness for osteointegration. In younger children, it's a 2-stage procedure. You have to place the fixture first, allow osteointegration of the fixture to the bone, and then there's a 2nd-stage procedure where you actually thin the skin and place the abutment. But in kids who are older than 3, you can combine this procedure into a 1-stage procedure. That's what we typically see here. What are the advantages of the Baha? Well, it's a simpler procedure. It's about 1 hour. You don't get anywhere close to the facial nerve. There are less complications. It does not preclude reconstruction, both Atreidoplasty as well as Microsia reconstruction. You can place a Baha early, and you can still go and correct their Microsia at age 5, and you can even still consider Atreidoplasty later on in life. The Baha is placed at a younger age, or it can be placed at a younger age. I think in the literature I could find Atreidoplasty is done as young as 4, but a Baha can be placed as young as 1. I will show you the hearing results with the Baha. It's more comfortable than the bone conduction hearing aid. And the cost, as I will show you, is comparable. So in terms of complications, the main complications are these 3: failure of osseointegration, skin infection and reaction to the fixture, and skin overgrowth. But these percentages are relatively low if you compare them to Atreidoplasty. And I think it can be easily argued that the complications in Atreidoplasty are a lot higher. If you look at the hearing, these are the studies that look at Baha hearing outcomes in patients with Atresia who got a Baha. And some of these studies compare them to their Atreidoplasty surveys. So you'll notice some of these studies are mentioned more than once. If you look at these studies, first thing I want to mention is that there are very few studies that look at this question. But if you look at SRT less than 30, it's comparable. I mean, this study shows only 54% got an SRT less than 30. But if you look closely at their study, their PTA was actually less than 25. So I'm not really sure why their speech recognition was lower than their PTA. But for the most part, pretty decent results. The air bone gap, this time meaning aided bone gap, was 100% in those that looked at it. And the average hearing gain, especially in later studies, are about 30 to 40 decibels. So these hearing results, if you compare them to Atreidoplasty, are a lot better. If you look at the cost of Atreidoplasty, this was a study done at the Children's Hospital of Pennsylvania, where they looked at their patients who received Atresia surgery, those that received 2-stage Baha and 1-stage Baha. And they looked at the cost of surgery, the surgeon's cost, the hospital cost, and they said that 2-stage Baha and Atreidoplasty back in 2005, maybe it's less than $10,000 difference. A 1-stage Baha, much cheaper. But if you look at their results and you look at cost per decibel hearing gain, you get a lot more hearing for your buck with a 1-stage Baha. And that's what their conclusion was. Maybe the Baha is a better way to go if you're looking for good hearing outcomes. Now, what are the disadvantages of the Baha? The main disadvantage that people report is cosmesis. No one really wants to have a metal implant sticking out of their skull. And no one really wants to have a big processor behind their skull. Another disadvantage is it has an on and off switch. Most people, on average, wear their Baha or their hearing aid for about 8 hours a day. So there's a huge amount of time when people are not optimizing their auditory stimulation. But the bigger question is it really, if you had a really good Atreidoplasty, now I describe percentages, but there are some patients who actually get an Atreidoplasty with a great hearing outcome. If you compare a good Atreidoplasty, do the Baha patients have worse binaural hearing? And the argument is that with the Baha, you are in fact stimulating both ears, both the ipsilateral ear as well as the contralateral ear. And the intracranial attenuation is quite low. So there is some suggestion that Baha actually is not good in speech in noisy environments or sound localization. So I asked the question, if you have a really good Atresia surgeon who can get a really good hearing result, maybe that's better than a Baha. So to address the cosmesis, there's a soundbite. I have no disclosures. I know some people here, some people here are involved in the soundbite. I think it's a really cool contraption, especially for older kids. It's only FDA approved in adults, but the oscillator basically is a mouthpiece that's placed in the maxillary molars, and then the microphone is placed behind the ear. What's great about this is that you don't have a metal implant behind that's sticking out of your skull, but in younger children, I don't think this would work. One, because they have baby teeth, so they don't even have adult molars to attach this to. Plus, this would be a foreign body for most children who are really young. So, but it's for like teenagers. I think this is a great alternative. More recently, in Europe, people are starting to talk about the Middle Ear Implant for Atresia surgery and for conductive hearing loss. For those of you who don't know what the Middle Ear Implant, the most common one described in literature is the vibrant sound bridge. But there are other middle implants, semi-implantable or fully implantable, that consist of an implant that's placed behind the ear subcutaneously, kind of like a cochlear implant. Then a wire is placed through the temporal bone. You have to drill through the temporal bone to place it. And then you place a floating mass transducer on the incus or on the stapes, or sometimes, if this is not possible, on the round window. And then basically you have an audio processor that's external that receives audio signal. It transmits it to the implant, which converts it to vibratory signal, which transmits that to the floating mass transducer. And if you have ossicles that can move, it can jostle the ossicles and create hearing, transmit hearing to the inner ear. Or it can be next to the round window and indirectly stimulate the inner ear. And the argument for the middle ear implant compared to the Baha is that this is very directional. You are directly stimulating one ear versus the Baha, which technically stimulates both ears. So this is mainly, the literature is mainly coming out of Italy and France and Germany. I don't think anybody's doing it in the United States. I couldn't find anything about that. But the preliminary results show that the hearing gain is comparable to the Baha, about 45 decibels, and the speech recognition threshold is also comparable to the Baha, about 20 decibels. So I think it's interesting. I would like to hear what some of the attendings who do Atreidoplasty and do otologic surgery, what they think about the middle ear implant, because it seems to be very popular in Europe. In addition to that, because it's early, people right now are saying there are no complications, they're not having any complications. I'm not sure what the final outcome of that's going to be. In patients with Atresia, it's going to be difficult to place this implant. You'd have to actually you'd have to drill the bone exactly like an Atreidoplasty, say high, superior, and enter the epitympanum, similarly to how you would enter it for Atresia surgery. So, in conclusion, I hope that I've shown you that during your evaluation of Atreidoplasty, you want to determine inner ear function, both audiometrically and radiographically. If you're considering surgery, really close to looking at that CT temporal bone and applying one of the criteria I described to you, or even using your own criteria. It seems like looking for normal middle ear anatomy is what's key to it, and looking at the course of the facial nerve is key to identifying patients who are good surgical candidates. I hope I've showed you that Atreidoplasty is technically difficult, with high risks of complications and hearing outcomes that are not perfect. And finally, there are other treatments such as the BAHA or the soundbite or the Middle Ear Implants that are maybe excellent alternatives. So I want to bring back the original algorithm which I showed you. And I think with what I found from the literature and just seeing how we're practicing today, I think this can be simplified. I think in patients with congenital oral atresia who have normal sensorineural hearing, whether it's unilateral or bilateral, I'd like to argue that all of them should get a soft band bone conduction hearing aid for that atretic ear, or a bone anchored hearing aid soon, mainly to optimize auditory plasticity early in life and to help with speech and language development. And then when they're reach age 5, consider the Microsia surgery. And then maybe when they're older, if it's feasible and the patient understands the complication rates, they understand what kind of hearing outcomes they're going to get, and if they want it, you can consider an Atreidoplasty. But perhaps, maybe I've convinced you with the BAHA and soft band bone conduction hearing aid that maybe this may not be an option in the future. So I'd like to thank all the otologists who have taught me so much in the last 4 years. I'd like to specifically thank Dr. Chang, who went over my slides, and Dr. Oglite, who let me play paparazzi in the OR on Monday, and Dr. Grigel for going over my slides as well. I'd also like to thank patient Amy, who I got special permission from to present her case. I'd like to end with a quote by the Ayurvedic surgeon who I described to you guys earlier. I think this has been an awesome experience to have to present grand rounds, but I think the most daunting part about it is having to present to an audience with experts in them. So I'll defer to those experts when it comes to further discussion about this topic. Thank you. Dave?
Hey, Barney, great talk. I learned a lot. But I wanted to ask you whether you thought it was a fair comparison to compare a bone anchor or a abutment with a hearing aid attached to it compared to Atresia surgery that is not aided.
Exactly, and that's what the big question is. There are some studies that say that up to 90% of patients who get an Atreidoplasty still require an aid. And that is a downside, I think, because a BAHA is basically an aid. There's some argument that an aided ear has still better hearing, especially in speech and noise environment, as well as sound localization than a BAHA. And so that would be the argument that an aid might be better. You might wear the aid longer. You can, so those are the arguments for Atreidoplasty with an aid.
Great talk. It was really, really good. Very good synopsis, and you did a great job.
Thank you.
Really learned a lot. This is one of the most difficult things. I've done several thousand otologic surgeries, and this is the most difficult otologic surgery there is. If anybody takes it lightheartedly, they'll get into a lot of trouble. And if they don't get into a lot of trouble, they'll just have a failure. A very unhappy patient. And we really have to discuss the long-term effects of this surgery with the patient. If you do this to a child, most of them will not be able to tolerate water sports. They just don't do well with water exposure. Even if you do the anterior canalplasty and you're lucky and you get away with it and they heal really fine, these are not self-cleaning ears. They need a lot of cleaning, a lot of attention. And they're lifelong patients. You will be seeing these patients and revision after revision. And so it's really a difficult undertaking. The cholecystoma is definitely there. When I did my fellowship at Aural, we were doing 25 to 30 of these per year during my fellowship. And then after that, in the 80s and 90s, I was doing a lot of them too. But then slowly, just kept falling off I do maybe 2 a year now. So it really has gone down quite a bit. And most of the patients opt for other options. So we have to be honest with the patients. The cholecystoma ones are definitely have to be done. I had a patient that had cholecystoma, so I offered to do the Atreidoplasty as well as removing the cholecystoma. And when I went through the risks and benefits of all the details involved, she said, just take care of the cholecystoma and close the ear back up. I don't want an Atreidoplasty. Really, literally, this was an adult 19-year-old that had cholecystoma in an athletic place. And she decided that, and she's on a swimming team and a whole bunch of other things, and she just said, I don't want it. So I think it's important. The advent of these new devices that we have, I think it's really helped as far as the hearing. So anyway, I think it's a great talk. You did a very good job.
There was a, thank you. There was a paper by Dr. Shelton recently that looked at hearing outcomes based on experience. And he says you need to do at least 30 years to have a good short-term income and 48 years in order to have a good long-term income.
48.
That's a lot of years. Considering I've only seen 2 Atreidoplasties. One was a revision and one was just last week. A lot of years to, it's like it's happening once or twice every 5 years. It's pretty hard to get to those numbers. Dr. Chang?
That was a really fabulous talk.
Thank you.
And I just came back from a Microsia and Atresia meeting in Sydney, where a bunch of the top Microsia surgeons in the world as well, they included a bunch of Atresia surgeons as well in this conference. And one of the things that people were really excited about at this conference was this new Sulfino device, which is a way to get bone conduction without having the abutment that emanates through the skin. So what you do is you place a metal plate inside the skull, but it's completely buried under the skin. And that metal plate just allows a device with a magnet to kind of stick on. And that the device with a magnet that vibrates, and you get bone conduction that way. So there's nothing penetrating the skin. The problem with that device, though, is there can be some problems if the magnet's too strong. You can get necrosis with the skin. So they've had a couple of patients with complications with that. So I don't know what the long-term results of this. It's a relatively new device. It's being mostly used in Germany right now, but it's now starting to be available in the United States. And that's something that people are excited about.
So we were just talking about this because with Dr. Sajati, one of the big downsides of the Sulfino device is that it's a magnet. Especially in younger people, they're not going to be able to go into an MRI. So you don't know later on in life when they need an MRI, you're going to be in some trouble with that. From what I understand, that device, those little screws are not they don't osteointegrate into the bone, so they're removable, which makes it somewhat beneficial. You can potentially take it out if you need to, versus a abutment you cannot take out once it osteointegrates. Dr. Ugly?
Oh, Ronnie, that was a great talk on a very complex topic, and I was kind of amazed at how you were able to synthesize all of the literature that's out there.
It took a long time.
Yeah, it was really, really nice. This patient is interesting in that she's had this her whole life, and she's gone to several surgeons to try and get it fixed. They all said she wasn't an appropriate candidate. But yet, you graded her, and she was about as good as you could get. And she really wanted the surgery, so we did proceed with it, and we'll see how she turns out. I think I've done a fair number of these, and I agree that they often will restenose, and sometimes you need to go back and fix it. Sometimes you don't. But the hearing results can be amazing. And I've not had the issues with water being a major problem. They do need a debridement, just like a mastoid bone needs debridement. I definitely agree with that. And, my trick is to make it really a big ear canal so that they all shrink. And you have to make it big enough knowing it's going to shrink. And hopefully it'll shrink proportionally and end up with just a little bit normal, a little bit bigger than normal size ear. But thank you. Thank you for doing such a nice job.
Do you find that putting up prosthesis, like maybe a week to 2 weeks after surgery, take out the packing, squirt a mold in, send it to the company, and then have them hollow it out so you can keep it there so it avoids the stenosis?
Is that something that's possible?
Yes.
I've never seen
Mold or something?
It's a mold.
On some of my cases, I've used kind of the same thing as the ear mold for a hearing aid, which you can vent.
Oh, all the way down to the drum?
Well, just short of it. That sometimes helps.
Interesting.
Yeah, I've done that actually a few years ago, but some of them they stenosis the mold actually. Stenosis is the congenital Atresia.
You have to operate to drill out the mold.
I have been able to keep a lateral stenosis open. It was actually just something I would have a patient wear at night. You could take it out during the day and seem to keep it open. It was one of the little tips that they use for tympanometry. So it wasn't even custom made, but she could put that in. It seemed to help her if she just wore it at night. But, it's hard to know what the long-term outcome of that is.
That was an excellent talk. I just want to mention something that might be coming in the future. The interaural attenuation by bone conduction is around 0 dB for frequencies of about 2,000 hertz and lower.
Really?
But as you go in higher frequencies, there is enough of a difference such that if you apply higher frequency bone conduction signals, you have clearly a right-left difference, which you don't have for standard ones. So as bone conduction transducers improve, or as the middle ear implants are done bilaterally, I suspect or predict that the binaural neural pathways will be improved as well.
It's good to know. Dr. Ben?
Mention the role of the middle ear, the vibrating transducer on the ossicles. For this application, you wouldn't put it there, you put it in the round window.
Yeah.
And that saves you, of course, you go to the mastoid, put it in the round window, and then the posterior part is like a cochlear implant, you have an external device, no post. And remember, air conduction driving the round window distinctly beats bone conduction every time.
That's the argument for any type
Every time. The energy for bone conduction is much greater, and that's why people aren't wearing bone conduction hearing aids if they can wear an air conduction hearing aid. So, with the floating mass transducer, you can put that on the round window, bypass scary drilling, bypass all of this stuff, go right through the mastoid, drop it in the round window. Now, if the ossicles are fixed, you may have an issue. There, but it works quite well. The reason you haven't been seeing this in this country is FDA issues. But just for your knowledge, if you want to know where the first round window implant was done in the United States, it was done 4 miles from here.
Really?
Yeah. And so just so you'll know that I wonder where it was done. And it was not reported. It's not in the literature. It did not have an IRB. Innovation. So it's done. And before that, the first one was done in Los Angeles. And a well-known otological medical group.
House is not open.
And it worked out perfectly, just so you know, the round window.